Thank you very much, Patrick, for this kind introduction. Thank you very much to Claudio and all the organizing for the invitation in this marvelous place here, close to Venice. And in the next 20 minutes, I would like to briefly review the concept and what are the technologies that we have available to remove CO2 from the blood. If we talk about acute respiratory failure, we essentially need to know that we have a dysfunction at the level of the lung. And this function is related to an increased alveolar arterial gradient in O2, and a decrease in lung compliance, and a decrease in ventilation. Physiologically, we try to compensate for these derangements, increasing the work of breathing. Once the work of breathing fails, we have two components that mixed into our blood. One, severe hypoxemia may appear, or severe hypercapnia, or both together. Since many years, the only approach we had to bridge until recovery of the lung was mechanical ventilation. But we know CDers said that mechanical ventilation may induce Willi and may induce multi-organ failure. Therefore, alternatives to mechanical ventilation come up early, and since 8 years now, or a little bit more, there are replacement therapy and that in addition may help to improve oxygenation, and these are ECMO, as you have been told yesterday, that helps to compensate. And the major point, I think it's an interesting point, that taking away the work from the mechanical ventilator, we may prevent Willi and multi-organ failure. On the other part, we are able, depending on the conditions that we have to deal with, that CO2 removal is sufficient to permit mechanical ventilation to be protective. What are the essential and how does extracorporeal CO2 removal work? And one thing it's important to realize, that for a given delta in PCO2, you have a much larger decrease in volume in CO2 as it is compared to O2. And the other point is that both equilibrates pretty rapidly when they cross the lung. And this physiologically difference between the two molecules allows that the effective CO2 removal is possible at very low flow rate. This is the rationale why low flow CO2 removal is possible with less invasive techniques. And this slide summarizes a little bit this concept. You have the hypercapnic respiratory failure at this end, which you can operate with low flow rates down to half a liter blood flow. And you have up here the hypoxic respiratory failure, where you need high flow rates to compensate for this lack in oxygenation in the blood. And the whole range is here available to you in our days. Which is the rationale and the concept to use extracorporeal CO2 removal? First of all, as I've told you, is to allow protective mechanical ventilation, to try to reach the goal of a driving pressure which is low and tidal volume which are low. And the other possibility is to correct the respiratory acidosis in order to maybe avoid the secondary effect of respiratory acidosis and mechanical ventilation completely. The indication for such concepts are maybe mechanical ventilated RDS patients with a driving pressure of more than 14 and a PaCO2 of more than 70 millimeters of mercury. And maybe to have in certain disease stages, such as COPD and cystic fibrosis patient with essentially CO2 decompensation, the options to avoid mechanical ventilation. which is the rationale behind and which are the concepts that support this strategy. One of that becomes clear during the last years that driving pressure as the ratio of tidal volume to lung compliance is an important predictor of mortality. As soon you have to increase, and these are for lung-safe data, the driving pressure above 14 centimeters of water, the outcome of your patient may worsen. On the other hand, in this nice study with almost 1,800 patients from Esteban's group that he recovered from several studies together, shows clearly that more sick your lung is, more severe your RDS is, and more longer you are ventilated. This is a study generating people that were in patients that were ventilated for more than 12 hours, yeah. The PCO2 levels above 70 millimeters mercury were independent predictors of poor outcome. And this was related to more complications. They had more barotrauma, they had more cardiovascular failure, they had more renal failure, and a higher mortality. In addition, elevated CO2 level have many biological effects that may be harmful. So in particular, you have a delay in the endothelial and cellular repair of the lung. You have a suppression of the host defense, and in later stages of the disease, more infections are possible and bacterial clearance is impaired. And you have, in addition, some effect on alveolar water clearance, so that RDS and the fluids in the lung cannot clear so fast. So these are the concept and the rationale why we should treat. We have seen that to remove CO2, we have a broad range of devices that can be used, but I think interesting are those devices here that operate at a low flow level and are less invasive, where you need less thick cannulas because you don't need that much flow. And this, just to summarize, we have essentially, we can distinguish 4 levels of support, where the high level of support is the full ECMO devices. You have these large cannulas, and most of your patients have to be sedated. But as soon as it comes to low level of support, where you can use low French, low size cannula, more and more you have the option to mobilize the patient, to keep him awake, and to avoid mechanical ventilation. That this concept works has been shown many years ago with the arteriovenous CO2 removal devices that show that the flow removal was dependent of mean arterial pressure, and by higher mean arterial pressure you had higher flow rate, and with higher flow rate you have higher CO2 clearance rates. Arterial venous CO2 removal, or as arterial venous renal replacement therapy, is depending on mean arterial pressure, and this is not so practical. Therefore, the industry developed this technique into a veno-venous replacement tool, and this is a standalone devices that you can buy nowadays that helps you to remove CO2 quite efficiently and less invasively. And you see here the effect of such a device where CO2 can significantly be decreased and kept low over a longer period of time. In addition, you have the option in this device to monitor CO2 removal. I think this is an interesting aspect when you are dealing with, because as with a renal replacement machine, the oxygenator may worsen, may decrease its efficiency. So you can, with this prolonged meter, see how CO2 decreases and how long your oxygenator is working nicely. And 2 types of membrane were available on this one of this first device that was able to do it, polypropylene membrane with a device that was approved for the use for only 24 hours, and they recently changed it to a polymethylpentane membrane which can be used for 5 consecutive days. And you see it works. CO2 decreases with both devices and can be kept at the lower level with both devices. You can improve with respiratory acidosis, while, of course, since you are just moving CO2, you will not change the PO2 to FO2 ratio. But this is a bridge to allow protective mechanical ventilation, and this is summarized here in these slides, where you see over the period of 5 days, you can keep the plateau pressure below 30 centimeters of water. You can increase PEEP while you are on the CO2 removal device, and so decrease driving pressure, recruit to the lung, and to maintaining the tidal volume in a protective range. That this concept can be pushed even further using such device has been shown by Marco Ranieri's group, where he randomized patients to a low, very protective mechanical ventilation with plateau pressure below 28 centimeters of water and tidal volumes that were very low. And he could show that in this highly protective ventilation group, it could decrease the inflammatory response due to the ventilator with using different cytokine levels. And Bine showed a few years later, using veno-arterial devices, arterial venous CO2 removal devices, that patients that were most sick with PF ratio below 150 millimeter of mercury may profit more from this CO2 revival over a long period of day and improve the chance to be weaned from the mechanical ventilator. This was not the case for patients who were less sick. So the concept is there. There are data supporting that we should go further on and study on these options in order to inhibit mechanically induced ventilator injury, as well as a consequence of the lung injury, multi-organ dysfunction. Let's move now to the CO2 removal in awake patient. I think this is an attractive way to proceed and to avoid mechanical ventilation. Is this possible in our days? Yes, it is. There are several smaller studies that indicate that the concept works and proves. One of the interesting studies that was using extracorporeal CO2 removal in awake patient waiting for lung transplantation. And the nice effect that these patients that did not need mechanical ventilation were more prone to have better outcome during waiting the lungs and after transplantation itself. More or less a disease that is predestinated to be treated with such kind of devices, RCOPD patients. And this was proved by Del Sorbo from Marco Ranieri's group in these 25 patients after comparing an actual treated group with a historical control group, that the incidence of endotracheal intubation could be significantly reduced after matching those patients with our statistical options that we have today. Another study was looking at that point as well. This was done with these ILA active devices, which use larger French cannulas, allows to go at a higher flow rate, and they use the flow rate of 1.5. Study was coming from Germany, and also they could show that intubation could be avoided in 1 of 2 patients treated with this system. What was clear in this study, as more you use larger cannula, more you have bleeding complication that may be avoided. So stay to low flow technique, use low flow cannula to avoid complication. And you can even push the idea further. And I think this preliminary publication of a few patients on mechanical ventilation that had to be weaned because of their COPD that led to intubate this patient. If you add in a difficult to wean patient extracorporeal CO2 removal, you can affect the mechanics of the ventilation itself. Interestingly, you see here that the swing of the esophageal pressure could be significantly decreased in all patients, that the esophageal, the transmural pressure could be decreased in this patient as well, and here the esophageal pressure as well could be decreased. And this translates in a reduced work of breathing in all 4 patients, and as importantly, a decrease in the intrinsic PEEP level of those patients, which is again associated with increased work of breathing. Interesting concept. And where is the future of extracorporeal CO2 removal? I think the future is there, and partially the future is already here available. There are some providers that allows you to compensate for the respiratory as well as the metabolic acidosis, combining these oxygenator with conventional CRRT technique. I think this is an interesting approach where this could be used in many patients with a combined respiratory metabolic acidosis, as you may find in patients with severe septic shock, RDS patient, and other disease states. And the proof that this concept is working comes from a publication in animals in our days. There are not publications in humans yet available. And this was an experimental model where at the first 16 minutes, these peaks where you had the dialysis unit and an oxygenator in series connected were exposed to hypoventilation while the tidal volume was decreased by 40%. What was the effect of this hypoventilation? The consequence, the CO2, as we may expect, increased to very high level. And then after 360 minutes, the combined treatment was offered to these patients. Apologize for the mistake here. And with the combined treatment of continuous renal replacement therapy and CO2 removal, CO2 could be decreased over time in this stain. This treatment was stopped there and CO2 was back to the initial level. And interesting enough, this opened as an additional option is that you, instead of heparin that had been used in all studies before, you can start using citrate for anticoagulation of this circuit. And this may be also another advantage. Still, you need 2 devices. You need an oxygenator and a hemofilter, but very recently the concept of a zero bicarbonate dialysate coming from John Callum's group was published in a model where he studied this opportunity, where he was giving blood that he recovered from animal. He was controlling CO2 in this blood via an oxygenator with CO2 addition, and then he let the blood go through a hemofilter where in the counter-circulation he let circulate a zero bicarbonate dialysate. And what was the effect of this experiment? He could show in this graph, I'll briefly explain you have here on the y-axis the expected removal of CO2, and here is the expected flow rate of CO2, and he tested it in different flow conditions at the flow of 11 ml and the CO2 inlet of 100 millimeters mercury with a flow rate of close 19 ml per milliliters with an CO2 inlet of 50, and again 11 with a CO2 inflow of 50. And you see which was the result if you compare the expected removal for the first combination was here, that you already at 180 milliliter per minute flow rate, you had a lot of removal, and this did not improve that very much if you even added flow rate. And for the other example, more or less the same thing. So a technology that is promising, it works in an experimental conditions, and maybe come to the use in patient in the future. To summarize, I think the current data suggests that low-flow venous vivo CO2 removal, as well ECMO devices, are safe and efficiently are able to decrease CO2 in the blood from our patients. This option can be used as adjunctive to mechanical ventilation in order to decrease the ventilator-induced lung injury. This in invasive as well in non-invasive condition, particularly in patients where hypercapnia may be avoided due to its harmful effect. At the end, there is in the future devices that allow a combination of CO2 removal and renal replacement therapy, and maybe in the more far away future, the CO2 removal using CRRT techniques only. Thank you very much for your attention.